Hi, everyone. Our presentation is about what is the data telling you. My name is Jennifer Staab. You can call me Jenny. And I'm one of the child life managers at Children's Hospital Colorado, and I also happen to help with the quality and research initiatives for our hospital. I ended up getting pulled into the extended reality program for that purpose and got so excited about what extended reality can do for patient outcomes and to improve things for staff. And so we are excited to share kind of what we've learned in that journey. And I'll let Jenny introduce herself.
Hi, I'm Jenny Gerson. I am the clinical research coordinator at Children's Hospital of Colorado. Are you muted? Yeah, you. So, an echo. I'm Jenny. I'm the clinical research coordinator for the child life department here at Children's Hospital of Colorado. And I work on all the research that we do in our department. I was hired with the goal of improving the body of evidence around child life related outcomes and support, which is very small. So we're working on improving that and growing the body of evidence. And right now we are doing lots of research with technology, which you guys will hear all about in a little bit. So I'm just gonna go ahead and start. Okay, so here are our objectives. We're gonna be talking about strategies for successfully implementing and integrating metrics to capture data related to the use of gaming and technology in the pediatric healthcare setting. We'll be talking about different ways to leverage data to evaluate gaming and technology programming, inform operations, and advocate for growth and resources. And then we will also be discussing barriers to implementing data collection and how we can overcome those obstacles. So pretty much everybody has been talking about all their research and all their presentations, which is great. So we'll kind of breeze through our background. As you all know, there's definitely been a lot of research in the last few years, especially about different ways to incorporate gaming technology into the healthcare setting, specifically looking at cooperation, decreased physiological arousal, lots of pain management types of research going on. This is just a little bit of a lit review that we did to look at some of the current trends in the research about VR, AR, gaming technology, all of that kind of stuff. So a lot of the recent research with VR has been for needle-related procedures, looking at pain and cooperation in those types of settings, as well as TBI therapy, more in a PT kind of environment. And there's lots of studies about pain, specifically in burn patients with dressing changes and things like that. We're also seeing a lot of technology-based cognitive behavioral therapy in lots of different environments for anxiety, for depression, for lots of things like that. We see a lot of literature about game-based therapies that lots of you are implementing in your facilities. There's lots of research about that, specifically with autism spectrum disorder and how the use of video games can be used in those environments for adherence to medical cares, for medications, for therapies, all kinds of things like that. And then these photos that I've attached to this slide are actually from the other side. This is a surgeon wearing a HoloLens in a surgery and using that to visualize what he is operating on. So the photo on the left is the surgeon, and then the photo on the right is what he's seeing, and you can kind of see the augmented reality depiction of what he's working on. And that's another really fascinating way that these devices are being used in the healthcare setting. So as you all know, there's lots of different types of ways that we can collect data. The three main categories that we're going to be talking about today are research, quality improvement, and program evaluation. And we've been working on lots of projects here at Children's Colorado in all of these categories, specifically for our gaming and tech program. So for research, the main, so for all these different kinds of data collection, the main thing that you want to be thinking about is what the goal is of the data collection. If you're trying to generate new knowledge or something that's generalizable to the wider population, that would be more of a research approach. For quality improvement, that's kind of looking at an existing practice and how you can create a body of evidence for that and capture that data. And then program evaluation is kind of looking at how you can improve programs that are already going on and improve their effectiveness, inform decisions about programming, all of that kind of stuff. So obviously there's lots of different ways to do that in all of these categories. Research is generally the most rigorous, the most time consuming, because the process of approval is so strict to make sure that everything is going as safely as possible and that there are as minimal risks as possible. So that is definitely the gold standard, are the randomized controlled trials and all kinds of other trials in the research category. Quality improvement is generally a little bit easier to get approved because you're not looking at specific outcomes of different treatments. You're just looking at things that are already happening. And then program evaluation often doesn't need any kind of extra approval. Usually you can just go ahead and jump right into those and start collecting data, and then you can leverage that in all kinds of different ways. And with all of these types of data collection, you can publish them in some way, shape, or form. So looking at publishing isn't the best way to determine which type of data collection you want to look at. It's better to look at what the goals really are, and then determine based on what your goals are, which of these categories you want to go to.
So yeah, I think that's where we really wanted to broaden people's perspective, that when you think about data, you don't have to necessarily jump all the way to research, because that can be really intimidating, especially if you've never done any data collection before, you've never been involved in research. We're really lucky we have Jenny Gerson here, that is our research coordinator, who can help with a lot of the data collection and helping us get through the IRB. It really does help us get over a lot of those hurdles. But that's why we want to talk about some of the other ways we've gone about collecting data here at Children's Hospital of Colorado to support our extended reality program, to just get your mind thinking about how you can start incorporating data, because what we'll talk about at the end is that the reason really to involve data is, one, to inform your practice. It's to help improve how your program grows and functions and operates, and also to help advocate for all the awesome things you guys are doing to establish the efficacy of that important work. And with that establishment of the efficacy, I think that's where we're going to really see a big boom in growth with this role. And so we'll start off with quality improvement, and just to get a little bit into a little bit more of the nitty gritty, really the goal with quality improvement is to take something that is already being has already been researched and already been validated. And there, as Jenny kind of spoke to, there's been a lot of research with VR and things like that. So you can take that research, you can then apply it to your hospital program, and the quality improvement part of that is really making it fit for you. Just because it worked clinically for research does not necessarily mean it's going to work in a real live clinical situation with your screaming 4-year-old you're trying to work with, or the 16-year-old patient with autism. It may look very different. So that's where quality improvement comes in, because it's really fitting that research into your program and seeing how it works, and it allows you to tweak it. They're called small tests of change, so you can kind of see how it's going. You can pivot rapidly. You don't have to get an amendment for your IRB in order to make any changes. You can just make that change, see if that change improved things. If it didn't, then you move on. So we'll talk about one of our quality improvement initiatives that we took on, and this was really, really early on when Abe started with our program. We wanted to collect some metrics on how the program was being received, what was working well, what wasn't working well. And really that was to maybe target where we maybe needed to focus, where we needed to adapt or change things a little bit. And so we established a really easy survey. We did it through a REDCap. A lot of hospital institutions have access to REDCap. So if you haven't heard about it before, it's worth kind of poking around and asking if you have access to that, and you can just get permission to have the access yourself. It's a great database because it's really secure, and for research people, it's really the gold standard for collecting data. And so you can collect data through a survey. What we did was made it super simple for everyone, and we bookmarked the survey link to a bunch of iPads and used those iPads by our child life specialists, our gaming and tech specialists. Even Jenny was running around trying to get surveys and things like that. And we really wanted to evaluate the perspective from a patient perspective, from a parent perspective, and from a staff perspective. So we asked kind of all three levels their feedback on, what they like. So I'll kind of share a little bit about that experience. So to start off, with the parent perspective, we just asked if they thought it was helpful to their child. Very simple question, and it was kind of a Likert scale, 1 through 5. And so a 5 meant that they thought it was really helpful. 1 meant that they didn't think it was helpful at all. And you can see we had a small sample size. It's not hundreds and hundreds of kids or thousands of kids, but that doesn't mean it can't be meaningful. It doesn't mean it can't inform your practice. So as you can see, the majority of the parents who were surveyed found it very helpful to their child. We asked them if they would be willing to use it for the future visits, and almost all of them said yes completely. We asked the patients whether or not if they had pain. We asked them if they thought it helped decrease their pain. So this was a smaller subsection of the patients that we interviewed or surveyed, because we needed to just look at the patients who were actually in active pain. And the majority thought that using extended reality really helped their pain. And again, very simple. It was just yes, no, wasn't a complicated tool. We asked the patient if they had anxiety, if they thought that using the extended reality helped with that, their nervousness at all, their anxiety at all, and most of them said yes. We asked them if they'd like to use it again, and everyone said yes. So again, that's just really quick and super simple ways to establish that what we were implementing was effective, and it was effective on the parent and patient level. We did also ask providers about it, and we honestly did not have like a ton of providers fill out the survey. But from the feedback we got from 2 of them, it was overwhelmingly positive that they would want to use it again, that it actually helped them with their treatment goals and things like that. So pretty exciting stuff. The next example we're going to give is just a simple program evaluation. I think for a lot of beginners, this is going to be your bread and butter of where you start, because the nice thing about program evaluation is like Jenny said, you don't need any approval for anything. And obviously you should probably tell your boss you're doing something like this. But besides that, you don't have to go through an IRB. There's no review board. There's not a lot of hoops to jump through, other than getting people on board to help you collect the data, or collecting the data yourself, which I recognize can be a barrier in itself. But program evaluation is really just establishing what metrics do you want to capture for your program, so you know where you're at, where your growth opportunities are, where maybe you need to focus more or build. And so that's the goal. And I think it's critical for really any new program, especially if you're donor funded, to be collecting programmatic data from the get-go. So that's what that's soapbox I'm on. And I think that with just some really simple things set up, you can do this fairly easily without a ton of, even if you don't have a ton of bandwidth. So here's one example. So when we started the gaming and tech position and Abe came on, one of the first goals was really to train all of our child life specialists to be more comfortable using the tech. And we thought that was a valuable aspect to the gaming and tech specialist position, because it really, that kind of train the trainer model expanded our army of people who could then use those devices through the patient. So while we only had one gaming and technology specialist, if he trained our staff, then all of a sudden we had all, our whole army of child life specialists able to do that. So we thought that was really cool. We thought it was a priority for early on within his role. And we also wanted to establish the value of that. And so we did some pre and post surveys with our team to kind of see the value add that brought. And so one of the biggest things that we saw is we did a really simple visual analog scale where there was 2 anchors. The 0 was they're not comfortable at all. The 100 was that they were very comfortable. And we asked them before they ever did the training how comfortable they were using extended reality to support patients. And we already had these devices, and we'd had them for a little while. So that's a good call out when you're looking at the data. And then after they received training, we re-asked them the same question. So you can see there was a major jump in how comfortable they felt. They didn't all go to 100, but that's not surprising, because really the training itself is the bridge to implementing, and the implementation is really where you're going to see comfort really expand. But just with the training itself, you can see that there was a huge jump in their comfort, and they felt prepared to at least start trying it with patients, which was the key. We also looked at kind of pre and post. How did they envision using the technology with their patients versus what ended up happening in reality? And that was kind of interesting. You can actually see that for the most part, what they envisioned doing, those team members who said, yeah, I think I'm going to use it a lot, or yeah, I think I'm going to use it some, but not all the time, or I'm not going to use it at all, it really kind of carried through to the post. So how they come in and their vision for coming in, we can be stubborn. It did kind of mirror that. We did see some movement, though. You can see that there were less people that said never, but there was also less people who said very often. I think there were some people who thought, I'm going to use this all the time with all my patients. I'm really excited about this. But then the reality of, everyday clinical life probably set in, and they use it maybe a little less than they had thought in retrospect. We also looked at just what are we using the most, especially as you talk about this army of child life specialists, what Abe's comfortable doing and the complexity level of what he's able to do is obviously not necessarily going to extend to every single one of our child life specialists. And that's okay. So what are we using? And especially as wanting to be good stewards of resources, especially when things are donated or funded through grants, we want to make sure that those are being used. And it's interesting to kind of see how that fell out. This is specifically for our child life specialists, so not looking at kind of what Abe's doing. And our child life specialists were most likely to use a Lenovo Nintendo Switch, the go-karts, and then the Omnibots and Glowforge were kind of the third tier, and that was really dependent on the units and the populations people were working on. So that makes sense. The Lenovo is definitely not the most complicated device we have, and it's not the coolest device we have, but it's probably one of the easier devices to implement, especially as a child life specialist. So that makes sense, and that's informative as we move forward, as we think about buying new devices or upgrading things. Where's the value add? Where we're going to put our money at, right? Child life training evaluation also looked at what they ended up using extended reality for the most. And so you can see here that the majority of our child life specialists are using it for normalization, with a close second being procedural support, which is pretty cool. I know these slides are so tiny. Okay, sorry guys. But this is looking at barriers, which we thought was an important part, and we did this pre and post. So we wanted to see what their perceived barriers to using the technology, if that changed at all with training. And it did change some, not a ton, but some. You can see that people were a lot less likely to say that it was time consuming to try to do. So that was a key. They were actually also less likely to say that their population weren't a good fit for technology, which was a kind of early on thing. And they were less likely to say that their preference was to use other things. So those were kind of key things that we did. The attitude did change, and that barrier did change after they were trained and had that knowledge. Pretty cool. This is when we're talking about program evaluation, I just want to do a quick shout out that if you are a gaming and technology specialist or some like term, I know we have all different titles, we are doing some benchmarking. Thanks to Child's Play, we've put out a survey to all gaming technology specialists to really do some benchmarking among programs about what those look like, what's your role called, what are your resources, how do you get utilized most, what are hours of operation, who do you report to, all that stuff to really help inform on a broader level the gaming and tech. So I'm gonna pop that into the chat when we're in the Q&A, just so that if you haven't already completed that survey and you are in a role like that, you can fill that out for us. And at another time, we will share that information because I'm sure it will be really informative and cool. So we'll go on to research next, and I'll let Jenny talk a little bit about what we've been doing related to research.
Awesome. So we have been working away with all of our tech research for the last few years since before I was hired, and certainly since I've been part of the team. We have some really exciting studies that we're looking at, mainly for different types of procedural support that we can use different types of technology. And something that we also really focus on is how we can use that technology in addition to support from a child life specialist. So all of our studies include groups where we are using this technology and the support of a child life specialist at the same time. And some of them also compare the tech with and without the child life specialist, or child life specialist and tech compared to other groups. So we're just going to go right into it, talk a little bit more about that. So this top line here, we have this study where we are looking at how we can use a virtual reality headset as a replacement for general anesthesia during lumbar punctures for leukemia patients. So we have lots of friends here in our Center for Cancer and Blood Disorders who are getting these lumbar punctures frequently, sometimes every month, sometimes every couple of weeks for their cancer treatment. And the standard is to be put under general anesthesia for each of those procedures, which obviously there's tons of negative side effects to anesthesia, and the repeated exposure at a young age, we can expose those patients to those risks. And in addition to that, if they are having anesthesia, they have to follow the NPO guidelines. They have to stay here longer. So that's our main goal, is to avoid all of that by using EMLA cream and this VR headset, in addition to support from our child life specialist. So with this one, this is not a randomized trial, so we give the patients who are eligible the option of whether or not they want to try to stay awake for their procedure. And then we also are following patients who are not staying awake for their procedure, who are being sedated as standard, so that we can see the comparison between that. And then we ask them some questions before and after about their experience. And we have seen a lot of the patients who have participated in this study have gone on to keep staying awake for their procedures in the future, either with the headset or just with other distractions like music or just talking to the team. And we find that just having the VR headset is sometimes a little bit of a gateway to get them to be comfortable with the idea of not having anesthesia. And then once they realize that they can do it, then sometimes they're able to stay awake even without any distractions at all. For this study, we used the Starlight headsets. Oh, am I back? Can you guys hear me? Okay. Not sure where I cut out, but we have a couple different games that we, thanks, Carla, a couple different games that our patients can choose between. And the reason that we only have a couple games is that patients are in a supine position for that procedure. So we are a little bit limited in the types of games that they can play, which is definitely a limitation that we're seeing, that a lot of the patients just don't like the games, but they still find that they are able to get through the procedure without any issues and continue to stay awake for the rest of their treatment.
Can you guys hear me? Oh, Carla said yes.
Oh,
Okay. So, okay, cool.
I'll keep talking. Can you hear me?
Can you hear Jenny G? Oh, okay. So we'll keep seeing if Jenny comes back online. I can keep talking. So with the augmented reality study, the goal really was to look at the different methods of preparation, and we wanted to see, especially as child life specialists, sometimes we think about the headsets, or people think about the headsets like, just slap a headset on them. That costs less than somebody's salary, right? And so that's one thing we wanted to kind of be able to push back on with the data. So it's actually has 4 different groups. That study has 4 different groups where we're looking at basic parent distraction and support using toys and different items, I Spy books and things like that. And then we have a group that gets basic child life support without any extended reality. We get there's a 3rd group who gets the extended reality but no child life support. And then there's a 4th group that gets the child life specialists and the extended reality. And what we've already anecdotally, we just wrapped up that study, we're doing the analysis right now, but what we've already anecdotally seen with that, which is kind of interesting for you guys to see, is that we had a lot more patients who were just in the augmented reality group actually have to unenroll from that group because we felt like it was not ethical to not provide them with the child life specialist. They were throwing off their headset, not using it, screaming, and it just didn't feel right to even keep them in that group. So we already kind of have some anecdotal evidence to show that really unattended without that coach and that person who can really help can be tricky. Are you back on, Jen?
Yeah.
Okay, I'm gonna let Jenny take over.
Sorry about that, everybody. So as Jenny was talking about, we with this study in the burn clinic, we have had to unenroll some of our patients because they weren't able to get through the procedure without support from a child life specialist. So while it is frustrating when we do have to enroll because then we lose the numbers, it's obviously still very valuable data that we can use to advocate on the other end for more child life support. And for the study, we're using the HoloLens headset, which I know a lot of people aren't super familiar with. It's a very interesting device that definitely has a little bit of a learning curve. So we've learned a lot about how to iron out the process with that so that we can make sure that it runs as smoothly as possible. We'll talk a little bit more about that in our slide about barriers and obstacles. And then our other study that we are working on is looking at different types of preparation for MRIs. And with this one, we are using the Kind VR headset, which has all kinds of content that is specifically designed for pediatric hospital patients. They have some apps that are kind of mindfulness based. And then the one that we use is an MRI preparation simulation that walks the patient through the different processes of what it's like to get an MRI. So it starts in the waiting room, and then it moves to the control room, and then it moves to the bed, and then they have the patient lie down, and it just kind of gives them an idea of what it will be like. And then if they move at all, it sends them a warning. So that kind of helps them practice the the part about being very still during the MRI, which of course is very important. So for that study, we use that program in addition to support from a child life specialist. And then our other groups are child life support alone, a video, and then our standard care, which is kind of our control group, where they don't get any formal prep from our team. They just get the prep from the MRI tech during the different parts of the scan and the prep to get up to the scan. This one is a randomized control trial that is also blinded, where I'm blinded, which has presented some new challenges for us as we get into that type of research. But of course, having that element does increase the validity of the metrics that we're using, specifically the behavioral ratings that I do throughout the time that the patient is here in our facility. I rate their behavior while they're in the waiting room, while they are getting set up for their MRI, and during their MRI. So in order for me to remain as unbiased as possible, we decided to have myself be blinded. So with that one, we have had to pull in other members of our team to do some of the other pieces of coordinating so that I can remain blinded. And then that way we have a little bit more of a little bit better data on that, so that it's a little bit less biased. Of course, everything inherently has bias in this line of research. That is one of the downfalls of a lot of our metrics are self-report data from our patients, which is inherently biased. So that's why we do have other metrics that we're looking at with our burn study. We also were looking at our FLAC rating from our nurses. We were looking at the time that it took to complete the dressing change, whether or not they received any pain medication, things like that. With our MRI study, we do a self-report anxiety rating before and after the MRI, so the patient can tell us how they're feeling at a couple different times, in addition to the ratings that I do. And then with our virtual reality for lumbar puncture study, we have questionnaires that we do before and after, where we ask the patients to compare their experience with the VR during their lumbar puncture compared to their last lumbar puncture where they were sedated. And then we also look at their vitals during the procedure. And we look at all kinds of other things like that. So between all those different things, we hope to get kind of a well-rounded look at all this data. One of the challenges with child life research in a medical setting is that it's hard to quantify what the support can do for patients. So in order to do that, we've added all these different metrics so that in addition to just the anecdotal evidence of kids saying, this was great, and this was really fun, and this was really cool, we also do have lots of numbers and hard data that we can use to translate into publications so that this can be disseminated in the language of medical research, which is really what everybody listens to in the medical field.
Yeah, and I just reiterate that I think part of our goal with a lot of this research and where we focused a lot of our energy is really being able to establish that not only is the extended reality devices themselves beneficial and helpful, but that you have to have that human resource along with it in order for it to be truly effective at the level that we're really wanting. So that's kind of key with our aims that we've been looking at. I just kind of want to give some ideas for potential metrics, different things that we either have been looking at here at Children's Hospital of Colorado or would like to look at here. Just some thoughts. Some of the things that we do track are number of patients seen, the time spent with patients, and then with some of the research studies and QI initiatives and even the program evaluation we looked at, pain and decrease in pain, decrease in anxiety. Can it help decrease medication utilization or sedation rates? That's pretty actually helpful, because if you can reduce the sedation rate, you can actually probably help increase throughput for that area, because anesthesia cases take longer. So that's affects the bottom line. Decrease ICU related weakness or delirium, faster return to ADLs, play, school, ambulation, first time avoiding, all those things, and then improve staff satisfaction. So did we make staff's job a little bit easier, a little quicker, a little bit more fun, especially in this current climate with concerns about burnout and resiliency and things like that? How how does it support them? And then procedurally, how does it help improve throughput or procedural efficiency? Those kinds of key metrics, while we might not be able to tie to a specific, dollar, because we're not charging for the service as of yet, there's no insurance reimbursement yet. As Dr. Marks talked about, we know that we affect important outcomes, and some of those outcomes can be tied to a bottom line in a little bit less direct way. So those are the kind of things that we're really trying to focus on. I'm just going to show you, I know this is kind of blurry, and I'm happy to share this with anyone who would like to see more. And Dr. Joe kind of went over this a little bit in his presentation, but we use Epicare. We set up a really easy data capture for Abe and all of our child life specialists when they're using extended reality, so that we can capture some really easy, quick metrics. And so we want to track the activity or what we're doing. We want to know what the visit outcome was. And also we have an assessment tool that our team uses. So we want to have some feedback on that. And actually, it's kind of cool. The field about their assessment actually pulls into a column on the patient list. So when you pull up a patient list, you can actually see if that child life that patient was already assessed by somebody from the child life team to be appropriate for VR. So you know right away, without even meeting the patient, that you could maybe bring your VR headset in for that patient and give it a whirl. So that's kind of cool. So from that data, obviously that accounts for our documentation, which is awesome. But we're also able to pull out reports from that. And so I actually am able to get, as one of the managers, I'm able to get data on really any increment that I want. The way I have it set up is that I can actually look at the past 24 hours and I can look at a month's data at a time. But I can also pull it for a year if I would like to. And the next slide, I will show you kind of what that looks like so that you can see. So we built this out in Tableau. And it is really, really cool. The top little part allows me to select date ranges, and then but the way it's going to pull is the last 24 hours. So I can get as of yesterday data. So that's really cool. The kind of the high level information we're kind of looking at is like the number of patients seen, the type of visits, but I can actually pull into the granular data and actually look a little bit closer to see what kinds of activities or devices or things like that if I needed to for some reason. So that's pretty cool. All kinds of stuff. And I do found this was really important for our child life team. I think it's been helpful for our gaming tech utilization as well, that if you built it into your documentation, it's not one additional thing that your team has to do because they already feel stretched thin. Data sometimes tracking can be a hard sell sometimes, especially for people who really just want to be bedside with patients and they don't want to do things that pull them from the patient bedside. So the easier you can make that documentation for them, the better. They already have to document on the patients they see. So then this is an easy way to also get the data that, somebody as a manager or somebody who's into the research side of things wants to know. And we've used this data for all different kinds of things, and I'll get more into that in a little bit. So leveraging data. This is the kind of why. Why do we care? I think data is fun. I know that most people don't think data is fun. That's okay. But if what I can drive home today is that data can be useful, that is what I'm trying to get across. So kind of when you're thinking about leveraging data, you want to think about what data or maybe you're already collecting. You might already have some really good data that you haven't leveraged yet. So think about that kind of scope. If you're not collecting data, what might be some simple things that you could easily collect? Or maybe there's data that you are documenting in the electronic medical record that you're not actually pulling, but maybe you can. So those are some questions to kind of ask. That's where the source of the data is important. Are you having to track in, your own Excel database? Are you tracking in a REDCap database like we do for a lot of our stuff? Or are you capturing it in the electronic medical record? So are there different ways you can kind of leverage that? Most things that go, or not most things, but a lot of things that go into the electronic medical record actually in some way can be reported on. So that's a key thing to think about. who has access to the data, and that is an important thing too. I know that can be a challenge because especially if you're a gaming and tech specialist and you report up to somebody who maybe doesn't really fully understand your role, it may be hard because you might have all this data, but you don't really have anyone to show it to or to have look at it or analyze it for you. But that's an important part, to kind of, what are you going to do with this data once you have it? And then how does the insights from the data inform decision making? That's really key. We use our data, and that's where I think we get buy-in from our team to actually collect the data. We use data every day to grow. We use it to determine, new FTEs, and advocate for those new FTEs and things like that. And so that's the key part as well. If you are talking to somebody who's really quantitative and data driven, and you're trying to convince them about the what the great program is that you have going, and that you need some more resources to really make it what it totally can be, you have to come at them with data, or it's often dismissed. And I think that's always been a fallacy for childlike programming for many years. We didn't really know how to do that, and we didn't really have the bandwidth really to do that. So here at Children's Hospital Colorado, we really try to build that functionality in, and it's paid off in a lot of ways, because we've grown tremendously over the past 5 years, and obviously our gaming and tech program is growing. And I think it's not solely due to data, but I think that's a big part of telling that story. Those awesome videos and the awesome tear-jerking stories and things like that are great. And I think they're like the icing on the cake, but you have to have a good foundation of data to support that, especially when you're going to your healthcare administration. And so I think that's really key to making sure that it's leveraged. But you have to figure out who's your audience, who's somebody that you can take this information to, get their ear, get their buy-in. Are there ways to get it across through presentations or publications or meetings or things like that? I think that's a key part, because if you're going to collect all this data just to sit there, people are going to stop collecting that data for you if it's not going to actually be leveraged. Some things to think about, and I think this is really kind of interesting aspect to this, is that there's different kind of ways to think about data. You can actually collect data retrospectively, which is most of what we do. So the data goes into Epic, and then we pull it out. So that's retrospective. It's going in, and we're saying, hey, we want to query this, and we want to see it, and we're going to look at it. It's really easy way to get data. Real-time analytics are trickier, but they're also they can be really informative, but sometimes it can be hard to get like up-to-date information. I'm trying to move more towards some real-time analytics because I think that staffing can influx so much on a day-to-day basis. Acuity from patients can flux from day to day, and we really, from a child life perspective, haven't had a good way to pivot super well to meet those demands, because we don't know until it's, everyone's feeling underwater. But is there a way to have more real-time data to help inform how we need to staff a specific unit or an area or a population? That's one thing we're excited about exploring. And then predictive analytics is kind of thinking about, can we predict what population might need, right? And so that's where potentially looking at, can you screen for appropriate use of this, or can you screen for the value of using extended reality with certain patients and project out how many patients are probably going to need an extended gaming and technology specialist in order to support, because then you can really start making a case for what the ideal staffing ratio is. And I think that's an important component to it. Just best practices, some things that are things that we know data can help benefit is what we actually do operationally. It can help us inform that worked well, that doesn't work well. We learned early on with the first version of our HoloLens that it was really heavy. Kids were actually sometimes, especially with long burn dressing changes, it wasn't actually a super good fit because those dressing changes can be really long. So things like that. And I'll get more into best practices at the next slide, but it can really help inform that. So that alone is a reason to do it, to help inform your operations and how you do things, and maybe even standardize some of those practices and training. to conduct a needs assessment. Where do you need more positions? Where do you need more resources to help justify positions? We use data all the time here at Children's Hospital Colorado for that purpose. And I think that's where the staff feel like it's a big win and really where they get bought in. It's great to cultivate and steward donors and the resources that you get. I think you're more likely to get money in the future if you're able to show effectively what you did with that, and that you can really speak to the value add that brought. And quality improvement, making things better, improving the experience, and affecting patient outcomes, which are some of the things we kind of talked about, looking at pain, anxiety, better coping, earlier discharge, just being able to get back to being kids. Just all those things. There's a lot of benefits to being able to capture all that. So what have we learned specifically? As you kind of heard Jenny when she was talking, we have a lot of a lot of our research is really looking at that procedural support aspect. And so we've learned a lot about what does that best practice look like. One thing we know is that children really need time to get engaged. Abe in his presentation kind of talked about this, that you want kids to be in that flow state ideally so that they can be well distracted. If you don't give them time to get in that flow state or get distracted, then you probably shouldn't have even bothered with the headset, right? So that's a key point, is that you have to allow some time for them to gauge before the procedure starts. Screening for whether they're appropriate. Not all kids are, and some kids might need more support to use the extended reality than others. Sometimes we have a child life specialist and Abe there at the same time, because maybe it's complicated what we're trying to do, or the kid needs a lot more support and the child life specialist doesn't feel like she has the skill set to maybe help troubleshoot everything. We love being able to mirror what the device sees, and that's because when they're locked in the VR, you actually don't really know where they are, and some of the ability to coach patients through experience and re-engage them into the distraction is lost for the child life specialist. And so it's really helpful if you can kind of see where they are. One, you then don't have to take the headset off, help them navigate to the right place, because you kind of know where they are within the headset and things like that. So setting up mirroring, while that can be a challenge, is really helpful when you can do it. Determine what game you're gonna use beforehand. That's where some comfort with the game in the first place is helpful. So you kind of know what might be a good fit. Make sure there's nothing going to be traumatic within the game that might be triggering, things like that. For the procedure specifically, you want to make sure the game isn't going to have the patient moving in a way that's going to be a barrier to the practitioner who's actually trying to do, the proceduralist who's trying to do the procedure themselves. And also just thinking about how long does this have to engage the patient, because you don't want to be in a critical moment of that procedure where they get bored with that game and you have to switch gears, and that could really kind of help make them lose momentum. So kind of thinking and timing things perfectly, so you kind of know, okay, this game is gonna get us through the procedure, or we might need to pause, switch the game, get them re-engaged in something else, so that it keeps the momentum going. And then I'm going to let Jenny talk a little bit about what we've learned about barriers and overcoming some of those obstacles.
A little too further. So as we know, there's lots of obstacles. You gotta mute, Jenny. We've got lots of obstacles, unfortunately, to the research process and collecting data. Most of these are specifically to research as opposed to QI and program evaluation, because that research does have the most barriers. The biggest one is just time. Every part of the process takes a lot of time that a lot of us just don't have. Both in the startup process of getting all of the forms together, getting the protocols, getting the consents together, submitting everything, all of that, the back and forth with the IRB, that can be very time consuming. And then during, once you are enrolling, the recruitment process, the assessment process, all of that takes a long time. And then of course, at the end, getting it all analyzed and writing it up, it all takes lots of time. So it's very important to have protected time at the least. We're very lucky here that we were able to get the funding and the time for my position, where I'm full-time. We know that is very rarely accessible to most people in most child life departments. But before I was onboarded, Jenny had protected time so that she could work on all of this research stuff. So having the protected time so that you can focus on research is important, because if you just have the clinical side and you don't have any protected time, it's almost impossible to get it all done. There are just not enough hours in the day. Another huge barrier is the specificity of the research startup process. Of course, everything that we do has to be by the book. Our IRB, as all IRBs are, is very rigorous, very strict, and obviously that is so that the research is the highest quality and is the safest, make sure there are no risks, everything like that. Because it is so rigorous, it is difficult to know what all the steps are that you have to follow and who to go to first and which forms to fill out and all of that kind of stuff. So having a specific person who is keeping up with all of those requirements, who's keeping up with how processes are changing, which sites you have to submit to, which approvals you need for which projects is very important. In our project, we have to submit to our IRB, we have to submit to a separate review board if we're doing anything with cancer research, which is a completely separate approval process. For some of these studies, if they meet the definition of a clinical trial, they have to be submitted to clinicaltrials.gov and then managed in that database as well. So there's just lots of databases, lots of reviews that happen. So having somebody who is keeping up to date, who is in touch with the governing research bodies at your institution is very important, just so that you can make sure that you're doing everything by the book, especially when the book is being edited every month, because everything is changing so quickly and medicine changes so fast, so all the requirements change. So it's obviously extremely important to make sure that you are keeping up with all that so you can do everything as it needs to be. Buy-in from the team can sometimes be challenging. Sometimes research can be seen as an extra thing that is taking time out of the clinical space. It's seen as an extra thing that in a fast-paced hospital, that there isn't always time for any extra steps. So it's important to do everything that we can to make the process as easy as possible for the teams in the clinical areas where we are doing our research, as well as for our child life team. So again, having a specific person who's doing the coordinating is really helpful. We try to do as much as we can before our patients arrive so that everything runs smoothly. So that's a lot of communicating both with the team in the clinical area and with our own team, and making sure that everybody is on the same page. Another way that we can get buy-in from the team is to tie it into goals and funding and FTEs and all of that. We have had in the past our team goal be surrounding our XRP program, and then having that as part of the goal really encourage our team members to engage in the tech and to become familiar with it all, and then they were much more likely to participate in all these other initiatives.
Okay.
And another another tie-in to that is funding. So it can be challenging to find funding for these programs. We've been very lucky to have funding from lots of great organizations like Child's Play. We use our Starlight Foundation headset. Of course, we work with our Children's Hospital Colorado Foundation to get us funding. And this is kind of a cyclical process where we have the funding for the research, and then in turn, once we have the data, that can lead to more funding and more FTEs when we have the data to show the effectiveness of these practices. Of course, technical difficulties are always a challenge. We have all of these amazing cutting edge devices that a lot of people are not familiar with, and even when we do as much training as we can, we still have technical difficulties. Some of those are inevitable, but if we do have technical difficulties that are so extensive that they compromise the use of the intervention, then that we do have to unenroll that patient. So we do everything that we can to make sure that our tech is working as well as it can be. One of the most important things is just having people become familiar with the tech, having our gaming technology specialist around when he is available to introduce these items to our patients is the most helpful. And he also helps the rest of our team become familiar with the different devices. And then once everything is running smoothly, that also helps with the buy-in from the team. Jenny was talking about the mirroring. Once everything is working as it needs to be, and when we have the time to make sure that we get everything set up well and it works well, then that feeds in to the buy-in, and then the tech can kind of speak for itself. When we have all of those things working properly, then our teams can see how effective these devices are and how much of a difference it makes with our burn study. Once we have the mirroring set up and our burn nurses can see what the kids are doing and they can interact with the technology, then it's even more effective. So doing everything we can ahead of time, and like Jenny was talking about, pausing to make sure that the patient has the time and space to become familiar with the devices before the procedure starts is just so important to make sure that everything runs smoothly. And then obviously making sure that everything is being updated and cleaned and everything so that we can spend as little time as possible with the research and just get right to the procedures and just make everyone think that we are just, running smoothly all the time is always the best way to do it. All right, I think that is it for us. Here's our references and we'll move to questions.